This week, headlines were dominated, rightly so, by a rare strain or rare species of Ebola burning through the Congo. And the world found out about it a month late, not because the science failed us, but because the systems we built to catch these things have been deliberately taken apart. This week's briefing is really about one question: what happens when you hollow out the infrastructure of infectious disease response right before you need it most? Ebola is the story, but the real story is everything all around it. The dominant story of the week was the Ebola outbreak, and I think it's probably the one of the most significant infectious disease events since COVID. There was a public health emergency of international concern declared. This is the third time this has been done for Ebola, but this is the first time the Director General, I think, rightly acted without convening the emergency committee because he needed to move fast. The official count is around 1,000 suspected cases. That's probably an underestimate. Modeling shows this has been going on for some weeks. That number is probably much higher. This likely will definitely become the second biggest Ebola outbreak in history, maybe even the first, hopefully not. This is caused by a species of Ebola called the Bundibugyo strain. This is the third outbreak that it's caused. It's caused outbreaks in the DRC and Uganda before. It's one that's not the most common. It's not the second most common. It's the third most common, but it's not in the standard diagnostic kits. And apparently they tested for this. It was negative. They tested for the major strains. It was negative. And that sample never really got processed rapidly to look for other strains of Ebola or other infectious diseases. And this is an area where USAID, which had been in the area, might have had a big role. But what it resulted in is a 4-week detection gap. And you give a virus like this 4 weeks to spread unimpeded, you're going to have a lot of momentum and a lot of catch up to do. It is spread to at least 3 provinces in the DRC: Ituri, which is the epicenter, North Kivu, and South Kivu. And now there are cases in Uganda, I think around 5 or so cases, including fatal cases, including healthcare workers. And I think we expect it to maybe spread to other neighboring countries like South Sudan. We've had 2 Ebola treatment units burned down by locals there who are kind of recalcitrant to the aid, that are opposing some of the burial practices that are being put in place. Not surprising. Outbreaks several years ago in North Kivu, they did some surveys afterwards, and 12% of the population thought that the outbreak was fabricated. So I think that there's a lot of work that's going to be difficult to do. We have one American infected. His name is Dr. Stafford. He's been taken to a hospital in Germany where he seems to be doing better. He's getting a monoclonal antibody. I think it's probably the one directed against the Sudan virus. It maybe has some cross protection. We'll see exactly what happens there. There are other countermeasures in motion. So the monoclonal antibodies are being pushed forward. That's through BARDA, the US government agency that's tasked with this kind of work. There's also an Oxford vaccine that's potentially deployable in approximately 3 months or so. I think it's important to remember that we only have countermeasures for the species of Ebola called Zaire. We don't have countermeasures for Sudan, Bundibugyo, and we don't have countermeasures for Marburg, which is not Ebola, but in the same filovirus family. Remdesivir and oseltamivir, I always pronounced that wrong, are heading into clinical trials. Those are Gilead antivirals as post-exposure prophylaxis. We'll see how they fare. Remdesivir didn't really fare well against Ebola Zaire in the past. We'll see if it has some role in post-exposure prophylaxis. Contact tracing is being very difficult there. I'm reading reports that maybe 1 in 5 contacts aren't being able to be followed up. There's shortages of simple things like motorbikes that are needed to get people to places to do the contact tracing. So this is going to be a long process. The authorities there are banning wakes greater than 50 people. We know that funerals can be times when the virus usually takes advantage, or settings that the virus takes advantage of to expand. And we know that that's probably going to be something that's somewhat resisted, as we've seen with the burning of certain Ebola treatment units. I think this reflects the fact that we have kind of, the systemic backdrop to all of this is kind of the hollowed out infrastructure we have for infectious disease emergencies. And it's not really just one event, although one event can bring things to light. It's really a pattern. So let's think about the CDC. They have a lot of people working on emerging infectious diseases. It was reported this week that 700 plus staff and contractors are gone, including the head of high consequence infectious disease. We know that USAID was dismantled. It was subject to DOGE. It had been able to do projects in the DRC. And even if these projects wouldn't have been able to have prevented this, they would have at least been on the ground and alerted people early that something was going on. They might have caught the outbreak weeks earlier, and that could give some advantage. It would have spared lives and decreased some of the momentum. And NIAID, which is part of NIH, the acting director, Jeffrey Tobenberger, stepped down kind of mysteriously. Don't really know why, but that's more infectious disease leadership missing in the United States. ACIP, the Advisory Committee on Immunization Practices, is effectively dead under RFK Jr. The federal judge had ruled his dismantling illegal, and then they were going to reconstitute it. Now that that recharter plan has been withdrawn, again, I think ACIP has become an irrelevant organization. One bright spot is BARDA remains functional. This is where the DNA for Operation Warp Speed came from, and you see them in action here with Ebola. They are the ones pushing forward the monoclonal antibody. I've seen some RFPs they've put out to use AI to make countermeasures against filoviruses. So BARDA still is one bright spot. But I think what I worry so much about is a dark ages mentality engulfing everything. The tools exist. The tools exist to master these problems, but it's the will in the institutions being stripped away. And I think that's more dangerous. Moving now to avian influenza. I think this is the pandemic threat that nobody is watching close enough. I think it is the biggest pandemic threat we face every single day. This week, I think I talked something about the avian influenza outbreak, and it gets a fraction of the coverage of some of these other infectious disease stories. So what happened this week? H5N5, which is a type of avian influenza, was found to have killed a polar bear and walruses in Svalbard in Norway. Remember, those are mammals. We have to really keep track and pay attention when mammals are getting infected with avian viruses, because we are mammals too. 4 new U.S. poultry farm outbreaks this week in the U.S., in Minnesota and Indiana. The question is, how much surveillance went on to the humans that work on those poultry farms? Did anyone get tested? What's the denominator there? I don't think we know. It's a black box. And I think that when you look at the Ebola coverage or you look at the hantavirus coverage, it's wall to wall, nobody paying attention to avian influenza, which I think is a bigger long-term threat. Measles, we continue to be in a record-breaking year. This is a vaccine-preventable disease, obviously, that's having its worst year in decades in the United States. And it has not a scientific root cause, but a political root cause. Pennsylvania, my home state, reporting 34 cases, the highest since the year 1991, when there was a major outbreak that included deaths. We have a multi-county cluster in Dauphin, Berks, and Lebanon County in Pennsylvania. Interestingly, the Pittsburgh Post-Gazette is reporting some really important stuff about school districts. 20 school districts in Pennsylvania since 2018 have been spreading disinformation about vaccines because they had put an anti-vaccine website on their website to direct parents to for information. Not surprisingly, maybe correlatively, you can't say causally, those school districts had lower vaccination rates. That may be because they are anti-vaccine school districts, but really something needs to change. People have to call to task school board members, school administrators, including school superintendents, for basically coddling the anti-vaccine movement and creating pest houses. The Utah outbreak is the active one that everybody is watching. It's the primary place where we're seeing a lot of measles cases go up. But again, Pennsylvania is now increasing as well. The South Carolina outbreak, which was the biggest of the year, is now over. There was a really good story looking at kind of what drove it. And it seems that Russian, Ukrainian immigrant communities had low vaccine uptake, and that was enough. So many cities have enclaves where there are people who don't partake in vaccination. And those are tinderboxes for outbreaks to occur in any city. It's these enclaves that are closely knit. That's what's driving a lot of the outbreaks. Mexico, they have a massive measles outbreak, but it's important to remember that that outbreak was caused by US and Canadian Mennonite populations. Again, these tight-knit populations. US and Canadians going to Mexico and mixing, or the Mexican Mennonites coming and mixing, and then starting outbreaks. It's really important to keep that in mind. And interestingly, the Mexican Mennonite populations, when people were going door to door, they found anti-vaccine propaganda there written in English, telling you it's being exported from the US. And I think all of this matters going forward because the whole policy apparatus we have, or the current one, ACIP, has been destroyed. So there will be alternative sources like the professional societies, like the Infectious Disease Society of America, the American Academy of Pediatrics, American Academy of Family Medicine, and hopefully they will be able to combat this. Now, looking to one of the root causes, RFK Jr. is the one of the root causes of all of our policy debacles right now relating to vaccines. He was in the headlines again this week because of his withholding of Gavi funding. Gavi is an organization that does immunizations worldwide, and RFK Jr. is not objecting to it on some kind of foreign aid principle. He's objecting to it because they use thimerosal. So thimerosal is a mercury-based preservative that is completely safe, but RFK Jr. has an irrational fixed idea that believes it's unsafe and it's essential for multi-dose vials, which are very important in the developing world. He's withholding it based on that, and he's withholding it based on the fact that they are using the whole cell pertussis vaccine as part of their DTP. So the whole cell vaccine is more effective. It's a little more reactogenic, or more reactogenic, not just a little more, but still very safe. This was one of the vaccines that was unfairly smeared by the anti-vaccine movement in a documentary called Vaccine Roulette, which led to the changing to the acellular vaccine, which we use in the United States, but which is less effective. He objects to those two things. It's not as if he's standing on principle against whatever this might be. He's just saying that these two fixed ideas of his need to be honored by Gavi. And I think that really shows how he's putting his irrational, nihilist, anti-human agenda above actually solving infectious disease problems. So I think this week, one of the things that I recommend, or I think that people should look at, is that we have all of these tools: mRNA vaccine platforms, molecular diagnostics, machine learning doing forecasting of infectious disease outbreaks, CRISPR antivirals are in the pipeline, expanded uses of vaccines. So 21st century solutions exist. These are masterable problems because we've solved a lot of the science and technology problems. But what we haven't solved is this dark ages mentality that continues to throttle us, that continues to hold back human flourishing. And that's why I say this is anti-human. This is why I say it's nihilistic. And I think we have to really question whether we have the will and the institutions to actually implement these tools that science and medicine have given us. I think that's going to remain the question. And it should be the question in everyone's mind every time they see an outbreak. They should be saying, well, why did this happen? What could we have done to stop it? Don't we have any tools to put into place? And I think that if you ask yourself that question and ask your policymakers those questions, I think we would go a long way to rooting out this dark ages anti-human mentality that's holding all of us back.